So today I'm going to present something. First I want to say good morning to everybody, I should say that. And I'm going to present something about how to best assess, how to optimally assess in hopefully the context of the Asia-Pacific cognitive change in people living with HIV and aging with HIV. I would like to thank the APACC committee for inviting me today. So next slide. So I have some disclosures, although they're not commercial. It's more where do I get the funding for my research in HIV and aging? So from Canada, Australia, and I have to disclose that I'm on a project with RINA, but that's actually positive for the current talk. So let's go right away into the topic. So we know that because of the successful treatment that people are on, people are living longer, and I think it's fantastic. But with living longer comes some caveats, and in the context of HIV, people, when they ask about their lives, start to say, well, I'm okay, but I could be better, basically. And so what we see is a combination of comorbidity that people develop earlier, and also in a greater number compared to people who are HIV negative of the same age. And one of these is, of course, cognitive changes. And the cognitive change, it's not going to happen alone. It happens in a context of also sometimes mental health changes and other changes that we see in people who are aging prematurely. So one of the things that I've done, and I will present the group that we have built together internationally, one of the things we have done, that we're trying to make a call to action globally. It is coming a bit as a later wave in the younger country of the Asia Pacific and Sub-Saharan Africa, but it is coming. There's a number of people who are going to be aging with HIV, and we think now it's time to have some level of refocus on the research, because those people are not going away. They are going to come in a high number, and we need to be prepared. And so we want a global response. I mean, when I say we, that group that we put together, and we want to also develop model of care that are of course, stigma-free, because we don't want to re-stigmatize people as they're getting older. And we want to train the healthcare professional, especially HIV specialists, in understanding aging, and also educate the community about what are the mild cognitive change that we're seeing. We also think there needs to be a refocus in terms of the research. So we now need to start to harmonize better with the existing knowledge and research outside the field of HIV in aging research, and start to develop the responses that are already available, but adapt them to people with HIV. And we need a dedicated research focus and also healthcare focus in low-middle income countries. So in that framework, what is really key to understand is that we need to do some level of early detection of people who are at risk of cognitive changes, and that can be done through early cognitive screening. This is ideally led by a multidisciplinary team because, as I explained, people have multi-comorbidities. So it is important to understand not only the HIV, but all the other conditions that people may be affected with. And so one of the key aspects as well is to hopefully involve the people, the loved one, the people who are around, the friends, and sometimes the family of people living with HIV and aging, because that's what's happening in the non-HIV population. The caregivers, the friend, the family are involved. So we need to start to think the same way. Although we need to be more encompassing, so it doesn't have to be the family, traditional family, it can be also the chosen family. In that early framework, so here it's I'm not asking you to read the slide, but it's just to show, for example, it's from the Western Australia Alzheimer's Association, and it shows that they've already thought about a plethora of intervention, including model of cares, when early intervention is at the key of that framework. And that's what we want to try to mimic, and at the same time keeping what's special about the HIV community also in mind. So what's very important, and that's just a little bit that I'm going to say about that, is that we're not talking in most instances with people who are living with HIV, we're not talking about any severe cognitive deficit. we're talking about the mildest of the mildest form. So maybe if some of you known people affected by brain fog during the COVID pandemic, that's something alike. But what you have to think is not a brain fog that's going to last 1 or 2 days. It's going to last for months. And so that needs to be intervened on. When people are impaired of vulnerabilities like that with their cognitive health or mental health, there are things to do. And it helps people, it empowers them to try to solve solutions. So when I say that that's what we see today, what I'm trying to say is that this is what we see in people who are on treatment. If people are not on treatment, they do develop the most severe form. Not all of them, but some of them will develop HIV dementia. So what we know as well, when we study people with the mildest form of cognitive deficit, if we follow them over time, we see that they tend to do less well cognitively as well over time. And we know that very well from outside the HIV field, that having a mild level of cognitive deficit one time in your life for a specific reason like having HIV is a risk factor for cognitive decline in the future. It's not always the case, but once you're at risk, then there needs to be things that can be done. And the idea is to avoid this decline, like we see in maintain brain health is a lifelong process. We want to avoid this decline that's going downhill. Oh God, it's already 13. Anyway, I better hurry up. So I want to, the slide that I'm providing here are going to be put on the website, Rina told me, and they're going to be seen as a resource. So all the slides have linked papers. So one of the things that can be used is what's called the Brain Health Services, the European Task Force. They've developed an entire framework on how to deal with early cognitive decline in people who are aging. That can be used and adapted to people with HIV. So the first thing they talk about is a model of health care. Those models of health care are really context-based. They will work in one country and not another. So here is the model in the UK. One thing that works probably everywhere is that they are integrated model of care, like the WHO integrated framework. One of the things that I've seen when I start to review this literature is that anything that has to do with cognition, however, is a little bit behind. So we need to improve that in the context of HIV. The next thing is risk profiling. Risk profiling is going to look a little bit different in HIV versus people who do not have HIV, but there are a lot of common grounds, and some of the common grounds are what we call modifiable risk factors, and they can be acted upon, and that's where we need to marry both HIV knowledge and, for example, cardiology knowledge, because we know people with HIV tend to develop cardiovascular change earlier. But what I'm trying to say in that picture is that it's a complex model. You need to take into account mental health and many other factors, including specific HIV factor, whether people have had AIDS or not. The next thing that will help in profiling people is going to be the cognitive screening. So I'm just going to go over this slide quicker. So there are some cognitive screening, computerized ones, that are better than others in the context of the Asia Pacific. And I've put two here. The pros and cons of the first one. The first one is a academic-led screening. It's great, it works very well to detect mild cognitive deficits, but it's not going to be available to the click of the finger or something on a website. So that's the case of the second screening, COGSTAT, for example. Both of them have been translated in multi-languages and also tested in low-middle income countries. But as soon as you go with a business-like model like COGSTAT, it's expensive. So what I'm saying here, you need to check for your setting what's going to be working best. There actually exists really cheap options using just paper and pencil tests. They actually work really, really well. A lot of those tests have been translated in a lot of languages, but there are caveats, and I will go through this in the next slide. So there are things to consider. So first, how commonly this test is used in your country, whether it's HIV or not, I would consider that. Has it been well adapted for your culture and your language? Can it detect the mildest form of cognitive deficit? How easy it is to use it in the clinic? Will patient accept that rather than another one? Is there training available? Some tests, some very simple screening I will show you have test training available. Do we have norms? So norms are like the reference benchmark that you see on a blood test. For example, that's what norms are. We have the same for cognitive testing. Do we have norms? And they're really important. So here I show an example of a study in Thailand that I actually take, I guess, what I'm saying into account. The MOCA, the Montreal Cognitive, is translated in many, many languages across the world. It works very well to screen people for cognitive changes, but it's not going to detect the mildest form of deficit. So what they've done, they've married that to very common neuropsychological testing. And when you do that, you detect cognitive changes very well. So that's one strategy. The other one that we've done here with Rina in Malaysia is we developed our own norms, because when we didn't use the norm, when we use a cutoff developed in another population, it didn't work very well. As soon as we started to use our norm, not only we detected probably the right people with cognitive changes, we detected also much less. So it's important to be accurate. You don't want to say people have cognitive change when they don't. That would be harmful to do that. The other thing that that is ideal to do as well, you should not only screen cognition, you also have to assess how people actually perform in their everyday life. And sometimes in some people with low literacy, that's probably the best thing to do in the first place, like the intrinsic capacity framework that Rina is a specialist on. I think you're going present on it. So you'd rather do that than do a cognitive test in that situation. But even in people who have cognitive changes, and it's mild, and they can do the cognitive test, assess function, or what we call everyday activity. It's very, very, very important. People can have, mild cognitive change, but in fact, if you look carefully at what they're still able to do, there could be big change in their lives, and vice versa. The next, I was going to pass on that one, it's going to be too long. So once you have a system in your clinic where you understand who are the at-risk patients in terms of HIV, risk factors, and also the other risk factors that I've talked about, aging being the number one, really, then you can start to streamline people who need care for their cognitive and mental health in a priority fashion. There are people who will never develop cognitive changes. There are people who will never develop mental health changes. There's no reason to put them through this if it's not necessary. So you streamline your patient, especially in a system where you have a high caseload. That would be the way to go. So that's something we've developed here for Australia, but the principle, the proof of concept is the same in any places. And then once you have that, then you can streamline your patient according to a priority setting, and you get them to do what I call here a brain health screen. So the brain health screen is not only the cognitive screening, it's the cognitive screening that you've chosen to be the best for your context and your clinic, but it's also assessment of everyday activity and assessment of mental health. You need to assess mental health in those patients. It's very important. If someone has acute mental health distress, like a very severe depression, you do not have them go through that care pathway. You first treat the mental health issue, and then you assess the cognition and the function later on. But anyway, so that care pathway that we developed here for Australia, the basic principle would apply. So you basically assess how first likely they have to cognitive deficit. If they're in a high profile case, then you review them thoroughly. So what you need to do, when I say you need, ideally you have to use geriatric principles. So you review above and beyond the cognition. You review cardiovascular health, bone health, and everything else. And then you try to develop a tailored patient-centered approach to treatment. So one of the things that I've mentioned earlier is how our field is multidisciplinary. So there's soon going to be a resource on the ASHM website, the Asian Australian HIV Medicine Society, that we've developed with Brosbourg and others about how to do a diagnosis with hand. So that's something that you can use, and that will review what I've just explained. The communication of risk. I think this is probably one of the most sensitive issues in the context of HIV. How are you going to communicate risk? So what we know, this research is just emerging in HIV, but we need to start to do the research for ourselves. But outside HIV, what we know is there are contexts where it is probably advised, and there are contexts where it is less advised. And I think I would look at this carefully. I guess in a nutshell, when you have a person who's very well informed about their mental health, their cognitive health, and they're forthcoming, and they want to be empowered, and they want to know, what can I do about it, you probably can communicate some level of risk in a context where there's something that you're going to do about it. if you can't do something about it right now, you have to be much more careful. And then in some cases, patients who are already quite severely affected, sometimes it's better to communicate the risk to the loved one or the family than the person themselves, because there's potential harm. So it's not one size fits all, but overall, it is advised to communicate some level of risk to be fair to the patient, like we've done in HIV, you know, where you engage in a sort of bilateral position, the care of your patient. So it's the same here. And I think what's really, really important to understand now is that there are things to do about especially mild cognitive deficit. When people are severely affected, it's a bit different, but here, because most people will have mild deficit, I'm going to concentrate on this. There are a lot of things that can be done. And those interventions, include cognitive health intervention, but they include a plethora of other interventions that had apparently nothing to do with cognitive health first. So they include, all those things that I talk about, and in HIV would be promoting, for example, cardio-metabolic health. It can be also reducing situation when people are into stigma. Anything that will improve mental health will really, really, really work. And there are really good things that works. All the psychosocial research across the world has shown that people gain a lot of benefit from it, okay? If people have a sleep problem, they need to be managed, etc., etc. And there is also some level of treatment that can be adapted. This is a slide from Scotland in the US. You don't take this slide as the truth, and it's an evolving knowledge, but I think he's done a marvelous job on showing what can be done. If I look at the non-pharmaceutical intervention here, there's a lot can be done, and they actually work pretty well. They have good large effect size when we look at the study. One of them is exercise, so people in the US are really keen on that one, but it may not be the best thing in the Asia Pacific. Same with the diet. A lot of research has been done, but with the Mediterranean diet, we don't eat Mediterranean diet here, etc., etc. So, and there's actually knowledge from the Asia Pacific that people may have some level of better cardiovascular health than back in North America, for example. So all of this can be adapted, but the message here is to say, there's nothing we can do. That is not true. There's a lot that we can be done. That's maybe almost a bit too much, okay? So internationally, outside the field of HIV, there is a bubbling, I would say, of research around neurorehabilitation, cognitive remediation, anything that has to do with either maintaining or slowing or preventing, or basically helping people in that vulnerability period when they've got cognitive health change. There's a lot that's going on. It's a rapidly evolving field, but what the message here is that things can be enacted to help people, and sometimes for them to improve, okay? So I just put here an Australian group because they're leading the research in Australia, but also internationally. But so that's the amount of things that can be done. It goes from, of course, mental health intervention, but also compensatory strategy. So you've all been in a situation where you were sort of like, what am I going to do about that? And once you know about the problem, you started to find solution and how to best manage and compensate for it. So that's what the process is. And then there are actually restorative strategy. And I think the one that everybody's talking about is multi-component strategy. And there's that very famous trial called the FINGER trial, which has changed a lot of things in the field of Alzheimer's disease, which is people doing exercise, people getting better diet, and better cardio health monitoring and general monitoring. And they do actually progress much slower to dementia. Or their risk is being reduced. So if we can do that in the context of a very hard to treat disease like Alzheimer's, we can certainly do that in the context of HIV. And last slide almost. So that everything that I've talked about, and sorry, maybe I talked a bit too fast. Hopefully not. No. Everything that I've talked about, so we have this group called now the Neuro-HIV Aging Advocacy Group, because we think, so that's the group where I was talking about this call to action and let's do something together. So we meet more like biannually now. It's international, now it's 3 years old. It includes people from the community, people with legal experience, researchers, clinicians, And we've been working on that now for 3 years, and it's open to new members. So the way to join is you email me and you get on board. And so this is my thank to all the people that I work with, and especially the HIV community people all over the world. And with this, I'm going to say thank you very much for your attention.